Well, it's an intriguing seminar. This is the first time that I've been associated with Wright State physicians, and the first time I participated in this seminar. And so there was a wide open variety of topics to pick from. It had something to do with orthopedics, bones and joints. I'm assuming that's why everybody's here. That's their interest. And in rheumatology, we take the medical approach to bone and joint disease, mostly dealing with and helping to prevent disease from getting to the surgeon. So ideally, if I'd done my job well enough and gotten to disease soon enough, then we can avoid surgical procedures, joint replacements and things like that. So that's my background. That's why we've developed this portion of the seminar. I guess by way of introduction, I'll introduce myself. Bill Venanzi, I'm a physician, a fellow of the American College of Physicians, and I joined Wright State at the end of last year, about December of last year, started clinic in January. But I've been here in Dayton, actually in Centerville and Dayton for the last 20 years because I was Air Force physician, just retired after 25 years. And really have enjoyed my time, obviously, at Dayton, Ohio, and Wright-Patterson, having stayed here for 20 straight years. So my relationship and association with Wright State University School of Medicine has been strong. I've been a faculty member in Wright State since at least '97 and associated with them before then. So it seemed like a natural extension to stay here and join Wright State physicians and stay with the same group of people, the same group of faculty that I've known, again, for 20 years. So as I talk, we're going to spend some time reviewing a history of rheumatoid arthritis briefly, and then move into new areas, things that have changed over the last 10 years and sometimes the last 5 years, with some new tests that we have, and some new thoughts on how to treat rheumatoid arthritis to make an impact sooner rather than later. Again, the goal is to prevent the need for surgical intervention using medication. There are a couple of break points in the talk when I'll ask for questions, and at the end, take anything you want. So it's a grab bag, open whatever questions you want, as long as it doesn't start with, I have. Okay. Now, I'd happy to do that too, but that's in clinic. Okay. Okay, technology here. Let's see. Yes. So we go way back to the prairie times when your physician had you chew on a piece of willow bark. And in that willow bark, and this was described in 1763, there was a substance. Nobody knew what it was, but it did help relieve inflammation. It was, 50 years later that salicylate was found to be the active ingredient, if you will, in willow bark. Probably didn't cost as much as therapeutics do today, especially if you had a willow tree in your backyard. But now we take from the salicylate, we add a few chemical side chains to it to make it an oral agent and call it aspirin. And in fact, aspirin was one of the first anti-inflammatory medications that we began using. As one then of our first disease-modifying anti-rheumatic drugs, DMARDs, we always say DMARDs, disease-modifying anti-rheumatic drugs, the first one was gold. Now, you've probably seen mummies and ancient folks buried with gold amulets, gold bracelets, much the same way as folks use copper bracelets. And that's in fashion now, too. You see it on TV. It's pretty, I don't know that it works, but if it works for somebody, that's fine. If you wanted to spend $30 in 4 easy installments, that's fine. But the gold salts were studied and really did change the inflammatory process, could actually heal erosions from the bone that had resulted from active inflammation. Gold, I loved it. Patients would come in every week, they'd line up and get gold shots in the buttocks, and it really worked well, as long as you could tolerate it. And gold became truly the gold standard in treatment for rheumatoid arthritis. If you want to think, though, of a rheumatologist's favorite, what's the rheumatologist's favorite medication? We get made fun of a lot for that. Is using steroids, corticosteroids. And we really find that if anything is going to turn off the inflammatory cascade, it's going to be steroids. So why don't we just use that? Unfortunately, corticosteroids are associated with a litany of side effects. So we just can't rely on that medication alone. Although instant gratification, it's really, really helpful to turn inflammation off fast. 1949 was our first use of cortisone. I was doing some antiquing down in the Southwest with my wife, visiting some shops down in the Southwest, and came across the cover page of the Ladies' Home Journal in about 1952. That's usually what happens. You hear that, I ask for questions. The crickets. So I came across the cover page of the Ladies' Home Journal. It said, "Vision to duplicate nature. Science duplicates cortisone." And we use it in the form of prednisone and many other forms, injectable and oral form. I kept that. I have it in a frame up in my office cubicle, my cubicle. Through the prednisone, again, 1955 by that time. But then through the 60s to the 80s, instead of using corticosteroids, we began developing these non-steroid anti-inflammatory agents, or NSAIDs, commonly Motrin, naproxen, Clinaril. The list used to go on and on. In fact, it was like every couple months a new non-steroidal anti-inflammatory agent was introduced to the market. Drug reps would come around, with lunch and their new medication. Not kidding. Every 6 months or so, there was a new non-steroidal on the market. And wouldn't you know, everyone said they were different. But in the end, they're all about the same. Lots of different medications, basically all doing the same thing. And then we realized that as we use all these medications, they're often associated with like the evil side effects. I like this joke, by the time your side effects take hold of you, you'll forget what you came to me in the first place for, because we're taking care of all the side effects of the medication. That was kind of cute. So after, and this is the good old days, and this is what I say the good old days. I finished my residency in medicine in 92 and a fellowship in 94. This is what we had to work with. Non-steroidals, we had gold injections and oral gold, methotrexate, azathioprine, cyclosporin, sulfasalazine, and leflunomide, only recently approved. That's Arava. That was it. And steroids, we used Plaquenil, hydroxychloroquine. And that was it, as effective agents. And so we'd find all kinds of ways to combine them, put 2 or 3 together. Then we started saying, well, if we want to do the best job as fast as possible, let's start on 5 and then taper back. So it was quite common to have patients on 5 medications at the same time, right from the time of diagnosis. And then we taper back once we get control of disease. That was the good old days. So let's see. The only thing that changed into the late 90s was the number of combinations we used. That was it. No new medications. It got kind of boring. Until nearly 2000, when the biologic drugs started to be released, started to come on market. So Enbrel, etanercept, infliximab, or Remicade, which was an infusion, was very popular because offices got to infuse medication and got to charge a lot more for it. But the course of treatment, $52,000 a year for the medication and its delivery. Remicade, $104,000 a year per patient for its delivery. Very, very expensive. Did they work? Of course they worked. In fact, they worked almost equally well. Enbrel worked actually marginally better than Remicade. And so they started the door, they opened the door to more and more biologic agents. Biologic because these are proteins, not chemicals, organic chemicals, but they're proteins that are delivered to the body to block biologic processes in inflammation. Slower roll. New targets emerged. IL-1, one of the enzymes in the inflammatory cascade, that is the cell signaling cascade for inflammation. Anakinra, or Kineret, was released. 2002, you get to see. Now, every year or two, a new medication being released in the biologic category. Humira and rituximab. Rituxan is a novel agent. It's an anti-CD20. CD20 is a cell marker on B cells. All the other medications deal with T cell and monocyte or macrophage interaction, whereas the Rituxan is a B cell targeted medication. Every B cell except the most junior B cell or the oldest B cell has that marker. So you really wipe out a lot of them when you use that. Kept going. The hits just keep on coming in terms of new biologic agents. Orencia, Cimzia, Simponi, Actimra, Xeljanz, a lot of real fancy sounding names. And pro golfers to advertise them too. I mean, it's amazing. You see the commercials. I can't avoid them. And flowers being picked, and people running and doing their crafts, and harvesting fruits and vegetables and stuff. Everything is wonderful. And then the fine print comes. It goes through real fast. Increased risk of lymphoma, leukemias, heart failure, many types of infections that could kill you. But still the flowers are growing, and the pro golfer is eating his family. So the key is all these medications work great, but they have to be selected individually based on the patient's needs, based on their response to other medications, based on other comorbid disease states, because it's not a one drug is appropriate for everyone. Patient characteristics such as their lung disease, heart disease, liver disease, drug delivery. Can a person do this at home, or do they have to come to the clinic and receive the medication? And what's better for them? The donut hole is a big problem, right? These medications, the meds, the prescriptions themselves cost over $25,000 a year, about $2,000 and change a month. How soon do you get into the donut hole? How much do you have to spend in? Anybody know the right answer to that? Nobody's over. I knew nobody was over 65 in this group. It didn't look that way. Middle age. When I talk about, and I do this to the residents, I talk about diseases of the elderly. My image of the elderly keeps getting older and older and older. I just celebrated my 25th anniversary since medical school. I went there, and we had a great time back in Baltimore. Had a great time, but two of my classmates have already died, and so mortality is starting to set in as they get older and older. But anyway, so my image of being old is now way into the 80s. We're right around the corner here. So we're saying the cost of the medication itself $25,000 a year. So in Medicare, you spend first on the plan about $4,000. And then the benefit stops until you spend another $4,200 out of your own pocket. And then the benefit continues. And I don't know, it's 80%, they pay it for whatever it is. So if you're on one of these medications, I guarantee it's going to cost $4,200 every year out of your own pocket, because the total cost of medication is over $25,000. So there are ways to, I try to counsel patients ways to adjust to that. Pick plans with supplementals, pick appropriate plans that cover medications better, things like this. We can also change the delivery of the medication into the clinic with certain formulations, and insurance will approve it. Therefore, you take the cost of the medication off the pharmacy benefit and move it to the medical benefit delivered in the clinic. And so there is some benefit to delivering medications in the clinic because it changed the way it costs for the patient. And I'm all for that. Make it as easy for the patient as possible. Okay. I'm going to move a little bit then to how we defined rheumatoid arthritis in the past and how we do it now, because there's a little bit of a change. But here's one of our first break points. Anybody have particular questions about medications and how we use or try to use medications? Any confusion about medications? Okay, good. So let's talk a little bit about our criteria. It's nice to think that whenever rheumatoid arthritis is discussed, the whole group is talking about the same disease. So that when we talk or try to look at an intervention in a group of people that have rheumatoid arthritis, I'd like to know that they all have the same thing. Okay. So back in 1987, the American College of Rheumatology, ACR, published our guidelines, our initial guidelines for the definition of rheumatoid arthritis. In order to be called rheumatoid arthritis, you had to have 4 of these criteria: morning stiffness, synovitis in 3 or more joint areas, synovitis in the hands, have to have the hands. Synovitis is our term, it's the medical term for active inflammation in the joints. Some people would say arthritis. Arthritis could be anything that hurts in the joints, okay? So when the rheumatologist says synovitis, he or she is feeling very carefully in each joint space, looking for bogginess, fluid collections, extra tissue, swelling, warmth in those areas. That's what we define as synovitis. It's the real active inflammation in the joint spots. So that synovitis has to be symmetric. That's for another point. Rheumatoid nodules, they're little extensor nodules on the skin. Sometimes they're firm along the bone, many times along the elbows, olecranon. Rheumatoid factor was a blood test. And radiographic erosions, so finding those bony erosions at the joint margin. These were the 7 possible points, and as you go through the patient's chart, their exam, you tried to collect, well, you tried to, but in order to enroll this patient as a patient with rheumatoid arthritis, we had to collect at least 4 of those items. Okay? One thing I'll try to point out is that in the absence of stiffness or synovitis, it didn't matter how many tests or x-rays were positive. If you don't have swelling, stiffness, inflammation in the joints, then you weren't going to have rheumatoid arthritis. Very important. So it didn't matter how many tests we did or how many x-rays we ordered, you still were not going to get rheumatoid arthritis. 4 or 7. So we looked at, in about 2008, we had a big convocation, you know, kind of like the Cardinals did. And then 2 years later, we published the new guidelines for rheumatoid arthritis, the new classification criteria. We did it in conjunction with the European group. It's kind of, I like their name, European League Against Rheumatoid Arthritis. It's kind of like the superhero group, you know, the Justice League, if you will. And we developed a point system. So a total of 10 points, we'll list them. You had to collect 6 or more of these points to be classified as rheumatoid arthritis. And this is the criteria that stand now. So in clinic, we will use this criteria as a guide to the diagnosis of rheumatoid arthritis. Do you have to have 6 to get medication? Nah, not in the clinical setting. But if I wanted to talk about your case, as a patient or as a group of patients with RA, then I say, oh yes, all my patients met criteria. Yeah. Okay. So a point system, joint involvement. One large joint gets you 0 points. Rheumatoid arthritis is not a one-joint process. As we talked in the previous criteria, it's polyarticular, which means it is a systemic process involving multiple joints. Okay. So 2 to 10 large joints only gets 1 point. But doc, you said I had multiple joints. But it is a disease of small joints. It is a disease principally of joints of the hand. But we didn't say hand in the new criteria. Got it? 1 to 3 small joints now, and you're on your way with 2 points, right? 4 to 10 small joints. You are halfway there to the diagnosis with 3 points. It's like a game show. And then you can go to over 10 joints as long as it involves small joints, and you already have 5 points. So the key is still the synovitis, the active inflammation in multiple joints, to include the hands. Because, I mean, half the small joints in the body are here in the hand. Okay. That's the joint involvement. We've added serology. Well, we've kept the rheumatoid factor and added a new test, which we're going to talk about, which is the AntiCCP, or cyclic citrullonated peptide. It's really hard to say that, so CCP will suffice for the rest of the talk. If it is negative either rheumatoid factor or NCCP, we usually will get both, 0 points. Again, telling you or implying how important that test is to the diagnosis. If they're low positive, 2 points. If they are high positive, 3 points. Essentially, again, high positive biomarkers for rheumatoid factor or CCP gets you halfway to a diagnosis. Okay. We also we retain acute phase reactants. That's the body's way of producing substances during the inflammatory cascade that interfere with this test we call sedimentation rate or C-reactive protein. 1 point. Why only 1 point? Why isn't that as important as CCP or rheumatoid factor? Because the list of disorders that can give you a positive SED rate or CCP is exceptionally long. So you could have had a common cold, the flu, before you came into the office, and have an elevated SED rate or CRP. Urinary tract infections, pneumonias, heart failure, heart disease will increase these tests. So they're not as specific for rheumatoid arthritis as CCP or rheumatoid factor. And chronicity. What do I mean by chronicity? Patient comes into the office and says, Doc, my primary care doctor sent me right over because today or yesterday I developed a swollen joint. Rheumatoid arthritis is a chronic inflammatory disease, not acute. So when patients present early, like within 6 weeks of the onset of symptoms, I really can't give them any points toward the diagnosis. So I'll usually say, well, you could have rheumatoid arthritis. Please accept a follow-up appointment in 6 weeks. I said, okay. So we re-examine folks at a 6-week interval to see if that inflammatory disease continues and satisfies a point for chronicity. Okay. Yes?
Did you give them medicine, or you just say something?
No. There are many things to do in the interim. Heck, sometimes I can even inject a joint. It's swollen. I love doing that. It's a procedure. It's pretty nice. I once thought I would be a surgeon, but I couldn't take the surgeon attitude, so I went into medicine. Anyway, so I love doing the procedures. We can inject things or take a Motrin, a non-steroidal, steroid. Love steroids. We can do a lot of things. But what I won't do, because it's a disservice, is label a patient as having a disease that they don't have. That's the real worry. Sometimes, and you probably recognize this, labels stick for a very long time. Like in an insurance company, you just get a hold of that, or an employment gets a hold of that, and it can be very bad for folks. So they won't get a label as rheumatoid arthritis. Understood? Treatment? No problem. Yeah. Well, what's the label? It could be just arthritis, non-specific arthritis, swollen joint of some sort. Yeah. Good question. It could be anything, really. But we have to be careful not to label people with rheumatoid arthritis because I have to defend that. Doc, you said I had rheumatoid arthritis. Why? What criteria did you use? Oh, well, okay. I was guessing. No. Okay. We talked a lot about the synovitis. That's our technical term for that swelling. It's a must. You must have it. And it must be in multiple joints in order to be classified as rheumatoid arthritis. If there is no synovitis, there is no rheumatoid arthritis. We get this Latin phrase, I didn't put it up there. It's called the sine qua non, without which there is none. Without synovitis, you can't have rheumatoid arthritis. Okay. So without synovitis, ordering a bunch of tests and x-rays is not going to help. It's not going to do anything for us except rack up a bill. We don't use these tests for screening. Oh, you have aches and pains, let's just take a bunch of tests. Mistake. These tests can be positive, and we'll talk, I promise, we'll talk about rheumatoid factor and CCP a little bit, because it's really important to understand the performance characteristics of any test that's ordered. And to know, the clinician needs to know, what am I going to do with the test result when it comes back? Is it going to make a difference in my decision making in helping this patient? If it's not, no business ordering the test just to see. Yeah. And many times we order tests and our reasons can be difficult to quantify. And the insurance company often asks, but Doc, why'd you order this test? I say, well, I just thought. Okay. The two situations. Sometimes the diagnosis is obvious. Why do you need to order any more tests? If the diagnosis is not obvious, you need to order tests that are helpful, not potentially misleading. Yeah. So it says offhand, I think you're suffering from an arrow through the head, but just to play it safe, I'll order a bunch of tests. Not the way to do things. Okay. New information. We have studied over the last 10 years a group of high-risk populations in which the prevalence, that is the amount of rheumatoid arthritis in that group, is much higher than the standard population. In the city of Dayton, let's assume that we're representative, of the larger population, there is about 1% of patients with rheumatoid arthritis. So it's a little less than 1%. That's not a lot of people, by the way. So if you see any, you want to send them to my clinic, really be good. Good. But there are high-risk populations. 2 or more family members, first-degree relatives, with rheumatoid arthritis would place that patient in a high-risk population. If you were high risk, if you were a Pima or Papago Indian in Arizona, you'd be in a high-risk population. You'd have to get on a plane to come to my clinic for that. So that's a little far away. But the prevalence of rheumatoid arthritis in that Indian group is 5%. That's pretty high, 5 times the national average. When you look at that group and do the rheumatoid factor test experimentally on all of them, you'll see that the ones that have the high positive test, and this it was defined as greater than 1 to 256, that's a titer, their incident rate, that is developing rheumatoid arthritis from that point forward, 48 cases in a 1,000-person year. So if the group has 1,000 persons, that's 48 cases every year. So in that high-risk population, maybe using that rheumatoid factor will identify those 48 that year. Might be helpful. Okay. Another high-risk population, that's the multi-case family history. So in this N of 370, which means they looked at 370 patients or subjects. In research, we call them subjects. 370 subjects who had 2 first-degree relatives with rheumatoid arthritis. Called them a high-risk population. In that population, the rate for developing rheumatoid arthritis was 8 cases in 1,000-person years. So they didn't have 1,000 people, they had a third of that. But again, think if it was 1,000 people, then there'd be 8 cases each year. Okay. If your rheumatoid factor, however, was positive, that rate jumps 4+fold to 35 cases per 1,000 patient years. Over 4-fold, almost 5-fold increase in the rate of developing rheumatoid arthritis. So now we're starting to think that in a high-risk population, knowing that somebody has a high rheumatoid factor tells us their risk of developing rheumatoid arthritis is much higher than normal, or the normal population. Okay. Oh, positive predictive value. Oh my God, I got to take my notes for that one. We talk about statistics, it's very tough. But here's what we taught to say that knowing the performance characteristics of these tests is very important. What does positive predictive value mean? I get a test, the test comes back positive. What does that mean in this case? How likely is it that the patient who has the positive test has the disease? It's not 100%. In fact, because the incidence of disease is so low in a population, only 1 in 100 patients, that positive test is still most likely to be a false positive test or indicate something else is happening because the incidence of disease is so low. Anyway, so the positive predictive value of that anti-CCP alone is only 5.9% in the general population. So again, you're saying, well, doc, why do you order that test? That's a good question. So it's important to order this test only in a high-risk population. And when I apply it in the clinic, that high-risk population is the person that presents with synovitis or X-ray findings that indicate rheumatoid arthritis. That puts them in a high-risk population. So the positive predictive value in this, actually it was this study that looked at that, so that multi-case family history, the positive predictive value was nearly 70%. In that group, the 5-year rate is extremely high. It meant that in that multi-case family history, if my subject, my patient in the clinic, has 2 or more family members, first-degree family members with rheumatoid arthritis, and that CCP is positive, it is nearly, I say nearly a guarantee, it is almost a certainty that in the next 5 years, at some point in time, that my patient is going to develop signs, clinical signs of rheumatoid arthritis. 5 years. That's helpful, I think. That, I think, gives us an opportunity to talk about early treatment or monitoring very closely in the clinic for those first few signs. Okay? If that CCP is positive. All right. What is that? Man, I keep talking about CCP. Everybody knows about rheumatoid factor, I'm sure. CCP, anti-cyclic citrullonated peptides. They are amino acids. They start as amino acids, arginine. When it is oxidized during the process of inflammation, oh, I said I wasn't going to do this, but I am. What is it? This? Oh, yeah. Okay, can I go over here too? Okay. There's an ammonia group here in arginine. During the inflammatory process, under oxidative pressure, oxygen gets substituted in that spot. That's in this citrulline. The citrulline is part of different proteins like filgrin and vimentin. These are proteins that we see in the joint space. That change, that one substitution, is enough to cause a conformational change in that protein. That is, it changes the shape of the protein. That is enough for the body to see it as, wait a minute, that's not right, and develop an inflammatory reaction or an autoimmune reaction. So when we look for these anti-CCPs, we are looking for the antibodies developed against citrullonated filgrin and vimentin. We use that now as a more specific indicator of joint autoinflammation or rheumatoid arthritis. We used to think it was great. It was the only thing that you're going to get CCP in is rheumatoid arthritis, but it didn't turn out so well. It still says 70+ percent of people with rheumatoid arthritis have this positive test, which is good. It's not 100% though. Sensitivity, I'd love it to be 100%. I'd love to be able to take a test and say, of all the people that have rheumatoid arthritis, I applied this test and they're all positive. That would be great. Doesn't work that way. And then specificity, this is part of the statistics lecture. Specificity says that of the entire population that does not have rheumatoid arthritis, I apply my test what should it be? Negative, right? It should turn up negative. Well, it does turn up negative, but only about 90% of the time. Well, how come it's positive in the other people? Well, there are other things that we didn't know about that do also produce these anti-CCPs. Some of the more common ones, various forms of hepatitis, other chronic deep-seated infections, tuberculosis, osteomyelitis, deep-seated infections, bacterial endocarditis, some of the same things that cause positive rheumatoid factor for sure. But the list of things is smaller. So we like CCP because it is more specific than rheumatoid factor. Okay. From a clinical standpoint, we'll often use both. They're both part of the classification criteria, so we'll get both. All right. Any questions about CCP? It's a new test, one of those new things we're using now.
How long has that been available?
Experimentally, probably been 10 years. Ordering it from the lab, 6, 7 years maybe, before it's been commercially available. Okay. Let's see. Move on. Okay. I like this. He's thinking, oh, this whole lecture's the Three Stooges. No. I want to get you to think of these diseases, these immune-mediated diseases, in 3 stages. Okay? 3 stages. The first stage is a genetic predisposition to disease. Okay? We've shown that in this group of Pima Indians. We've shown that there's a genetic predisposition in that other group of subjects with first-degree relatives that have rheumatoid arthritis. So there is a genetic predisposition as the first stage. Okay. Second stage, the presence of a biomarker. Once the gene, and something has probably got to affect that, be it environmental, be it age, something changes in our genome to turn on a segment that then creates or helps create a biomarker, something we can measure. In the case of rheumatoid arthritis, it's the rheumatoid factors, or it's anti-CCP, or it's other antibodies to inflammatory particles. And then the third stage is the development of clinical disease. That is, swelling in the joints, erosions in the bone, rheumatoid nodules, the actual criteria that we see on exam and in history. This same process occurs in other autoimmune diseases. Autoimmune thyroid disease, autoimmune diabetes, the same thing occurs. There is a genetic predisposition, then a marker, a biologic marker that we can look in the serum, antibodies, then the development of clinical disease, be it overt thyroid disease, TSH tanking or going up or coming down, or in diabetes, the development of hyperglycemia. That's the final stage, the development of overt clinical disease. Okay, let's keep that in mind. So, if we have a way then of looking at the patient in the clinic and saying, 1, do you have the first stage, a genetic predisposition? Is it time to treat you yet? Can I look at your genome and say, oh, you have this marker, this marker, this marker, better start treating disease that doesn't yet exist? I don't know. These are rhetorical questions. Anybody has the answer, just put a hand up. How about once the presence of biomarkers occur? Oh, you have a positive rheumatoid factor. Should we begin treating you for that disease, even though you don't have evidence of the disease yet? I don't know. Then you got to think, who's going to pay for it? Insurance company going to pay for it? You don't have disease yet. Doc, what are you charging us for? The question is, how early can we offer medical treatment, or how early should we offer medical treatment? Does the risk versus benefit in applying these medications may cause lymphoma, may worsen systemic infection, et cetera, may cause heart failure? Should we apply those medications when the person doesn't have yet evidence of disease? It's a tough question. No, it's a good question. What does autoimmune mean? Very good question. It means that the inflammatory process that's occurring in rheumatoid arthritis is directed at yourself. It's directed at your own tissue, as opposed to, I got a splinter and I got swelling, redness, because my immune system is trying to fight the splinter. In autoimmune disease, our body, in a sense, our inflammatory process turns against our own tissue. That's autoimmune. Okay? Nope? Okay. Rheumatoid arthritis is such an autoimmune process. In fact, most of the things I deal with every day are autoimmune processes. So in order to turn them off, my target is the immune system. So I'm using these medications to block the immune mechanisms that we often find helpful in, like, fighting infection, in surveillance of tumors, and I'm interfering with it. I'm mucking around to turn it off. No problem. Again, how early should we offer medical treatment in the patient who doesn't fulfill classification criteria yet? We actually still do that. We often call a patient early rheumatoid arthritis. So do you have it or you don't have it? What should I write? You only have 5 points. You don't have 6. That'd be a little rhetorical. Should I give you medications that can cause serious infections, can create congestive heart failure, can cause liver damage? No, probably not. I have to be very careful about that. It is a risk-benefit discussion with the patient. It's not always about me. It's about that interaction with the patient. Okay. What evidence do I have? I like using evidence. I'm not the orthopedics. I like using no. We like using clinical evidence. So I do have evidence in high-risk populations, such as the Pima Indians, such as that subject with the family history that's replete with rheumatoid arthritis. I can treat the Pima Indian that has a high rheumatoid factor but no evidence of disease yet. I can give that individual, I hate labels, treatment, and I can delay the onset of the rheumatoid arthritis. I can delay the onset of the clinical evidence of disease. Yeah. In one of the studies, about a year. Is that long? It's a year. That was their treatment regimen. They didn't use chemotherapy. Okay, using things like Plaquenil and methotrexate, which are milder and gentler, which is probably appropriate. Prevention of a disease, not yet established. I have no study which says if I begin treating rheumatoid arthritis before disease shows up in this high-risk population that I can prevent rheumatoid arthritis from showing up. Wouldn't that be the Holy Grail? If there was a sign that says rheumatoid arthritis is coming, and I can give you a medication that prevents it from coming. That's the Holy Grail. Okay. Nevertheless, if I see a patient in a high-risk group that has some evidence of disease, biomarkers, or the earliest clinical evidence, maybe not yet meeting criteria, then I can follow that person very carefully, working with their primary doctor to manage whatever symptoms they have. Follow closely. Re-examine in 3 months, 4 months, re-examine in 6 months, so that I can intervene as early as possible, either once criteria are fulfilled, or they say, no, ma, I can't, let's start now. And they accept the risks of the medication and treatment. Okay, I'm okay with that. But the ability to follow persons carefully over time is a benefit to having them in the clinic. It's a real benefit. Study after study shows that in rheumatoid arthritis, outcomes for patients far better in the hands of a rheumatologist than in the hands of family practitioner, which is okay. We study this stuff for years. We know how to do it. Okay, sorry. That's about earliest testing, intervention, and the biomarkers that we now develop. Questions? How will I know? You just come in every 4 months and just say hi and, did the label show up? Did it show up yet? No. By taking an objective look every visit in a setting of rheumatoid arthritis, the only way we're going to know that the disease or condition is changing. Clinical scoring tools, we need to use them. The hey, how are you doing? That's good for a portion. The patient's assessment in my clinic is good for 1/3 of the vote. Is good for 1/3 of that score. It's called a global health assessment. And is 1/3 of the DAS-28, Disease Activity Surveillance 28 count. I'll ask the patients, on a scale of 0 to 100, how are you feeling today? How is your arthritis doing today? 0 being no symptoms, doc. I don't even know why you keep calling it arthritis. 100, they say, I had a hard time getting in the door. Yeah, no. I couldn't even get in the door today. It was so bad. Give me a number. I write that number down. The best tools include an additional measure by the doctor and an additional measure from the laboratory. So this DAS-28 includes all three. So to measurement number 2, I go through in the examination an exhaustive exam of the 28 joints that count. I actually use a computer because it's a lot easier. Yeah, the 28 that count, yeah. Because the DIPs, these fat knuckles out here as we get older, they don't count. Sorry. Yeah, I know. They don't count for rheumatoid arthritis. And in fact, for this scoring system, the joints in the feet don't count either. So, and the knees, the large joints, don't count. Shoulders will count. Elbows count. All the joints in the hands, except for the DIP, will count. Anyway, I like using the computer because I can just mark them. Yeah. And I look, and on the exam, I'm looking for tenderness when I examine them. And I'm looking for that synovitis, swelling, when I examine them. And you get points for that. Not that you really want points, but Again, it's like a game show. And then the laboratory assessment, I can use either the sedimentation rate or the CRP measured in the lab. Put those into a long formula, which I'm sure I didn't put up here. Oh, I did. It's fortunate for you. No, don't bother writing that down. There's no test on that. You put those into the formula, and it gives us a number. Now, that number alone is of very little value. But following that number over time, maybe it's getting worse. Maybe it's going from moderate disease activity at a number like 2.9. No, I say moderate. Going from low disease activity, like 2.9, up into the moderate category in the high 3s, or in the severe category, I think it's 5.2, something like that, 5.1. That's it. That's going to tell, hey, doc, maybe I'll do something about that. Maybe I'll change medication. Maybe I ought to add a medication. Maybe I ought to increase a dose. And when I go to the insurance company and United says, oh, doc, that costs too much. You can't do that. I said, well, look at the patient's numbers. Look at this objective data I have. Your patient is doing worse. What would you like to do? Aetna? So I can argue with this objective data that it's time to make a change. And then on the other side, and patients love this, my number's going down. It's great. We have a little celebration. It's great. And then at a time when you hit remission for 6 months, we start peeling some of these medicines off. Great job. Until we start eliminating some treatment. And if you can eliminate some of these medications, then you eliminate those side effects. Less infections, less risk for tumors, less risk for congestive heart, less risk for liver failure. So that's a time to celebrate. Get the number below 2.6, call it remission, hold it for 6 months, according to my guidelines, the American College of Rheumatology. We start peeling medicines off. That's great. Objective data, okay? Very important. Yeah, maybe that's a comment there. How do I know the patient has not responded to drug X? Look at my data. Look at the patient's data. They haven't responded. Okay. All right. Damn, time flies. Take-home messages. I love it. Take-home. I like this. Take-home. Our criteria have changed. But we still stress the importance, the absolute need for that synovitis in order to have or be classified as having rheumatoid arthritis. That synovitis is of critical importance. In the absence of the synovitis, just running a bunch of tests to see if they turn out positive is wrong. That's not the way we do informed clinical medicine. And then we now recognize that there is an opportunity to intervene earlier in the course of that 3-stage development of autoimmune disease. We have to do it very carefully. We have to do it with informed judgment between the patient and the provider and understanding what the medications could do. But there is that opportunity in a high-risk population who has positive biomarkers, rheumatoid factor, CCP, there is an opportunity to help, even if it's just right now delaying the onset of actual symptoms of disease. And lastly, we must rheumatology must use objective measures to follow the clinical course of our patients. I love talking. I shouldn't point to anybody. I can't do that. I love sitting in the office and talking. Really have a fun time with the patients. I got to get down to business sometime. And keeping that objective data is really, really important. So I appreciate the opportunity to collect that and then to show anybody who wants to question, like Aetna or Humana, question my judgment on a patient. I'd like to get them for that. What I have here, additional resources, folks, I think they're listed in a handout somewhere. Good resources for arthritis information. The read my blog, I have RA. That's probably suboptimal, but arthritis.org, Let's Talk RA. These Arthritis Today, good references with information about rheumatoid arthritis and other forms of disease. And so I think that's all I had. I think go through my notes and say, did I miss anything? Because I wouldn't want to gyp these fine people. Yeah. Right. What happens? What happens in the development of rheumatoid arthritis? You recognize it has to start somewhere. Obviously, it has to start in one joint sometime. The truth is, you make my job a lot easier in waiting because it's obvious when you come in, 2 years later. But it is a very slow process. I tell you, the other thing I've learned over years in dealing with rheumatoid arthritis, the patients with rheumatoid arthritis are the most stoic people in the free world. No, doc, that doesn't hurt, and it's like this big. Because this is developed slowly over a long time. Oh, I was just stiff for a couple hours in the morning. I worked it out. It could be abnormal. So it happens slowly over time. People accommodate to that very well. And you don't do anything about it. Yeah. So it can sometimes put the provider behind the 8 ball a little bit. But as soon as we can intervene with the objective evidence of disease, or if you're in a high-risk population, maybe a little bit earlier, the better. If you wait 2 years, is it too late? No. It's never too late. I believe it's never too late. Okay? Rheumatoid. Rheumatism, all the same root word. I'm on tape here. Somebody's going to say, oh, no, it's not Greek. But I think it is Greek. It comes from a word meaning like fluids, like evil humors, things that a part of that inflammatory process. Something evil is, some evil fluid, rheumatic process is creating this inflammation. Let me go back on the tape. I was going to say, well, that wasn't right.
You're saying it's a slow process, but can there be like a major attack, like wake up one day almost?
No, that's something. Can it be an acute process? And the answer technically is no. But could you have had a viral infection, parvo B19? The kids get that, and they get that red cheeks, flat face appearance. When adults get it, they get an acute arthritis. It looks a world like rheumatoid arthritis. And in fact, if you got into my clinic quickly, and by the way, you can because I really have some openings. If you got into my clinic really fast, and I tested rheumatoid factor, which I shouldn't do, it might even be positive. So what the answer is, something else caused an acute arthritis, but that something else may be the trigger that turns on the chronic rheumatoid arthritis in someone who is susceptible. Lyme does it quite frequently. Someone who's exposed to real Lyme, like the deer tick in New England, the real thing, not I had a test, that can generate a chronic inflammatory process in the person who is genetically susceptible. They have a gene that includes the HLA-DR4, or that includes the shared epitope. Those patients have a significant risk of developing chronic arthritis, not chronic Lyme, but rheumatoid arthritis because of that exposure. So you can develop an acute arthritis that's not particularly rheumatoid, but is the trigger to develop chronic arthritis. Is that helpful?
Yeah.
Yeah. Yeah, yeah.
And then now I'm under control, but I was just like, I felt fine. And then I didn't.
There was something else.
Especially like the hands and stuff. You know, the joints can be down and stuff, and then doing a lot of hand movement, keyboarding and stuff. Does that trigger in any way, you know, a lot of activity on those joints? Obviously make it sore, but
Right, right. So you're asking about does certain activities trigger, make worse, or perhaps make better rheumatoid arthritis fundamentally? We believe in our heart of hearts that activity of the joints is the best thing for rheumatoid arthritis. Now, it has to be graduated. In other words, it has to be monitored, supervised. In other words, worked into. A study done just last year, 2013, yeah, that was last year, looked at the value of occupational therapy in rheumatoid arthritis. By far, that group did better. The number, 2.2 points in DAS-28. 2.2 points better than the group that did not have occupational therapy to work their hands. That's the rheumatoid. Rheumatoid benefits from activity. Yeah. That's why you're stiff in the morning. But as soon as you get working, it feels better. Yeah.
You just explained something, because I had a music teacher some years ago, who played piano and all that. This is his job and everything, nightclub and all. He had arthritis in his hands and fingers. I'll never forget him telling me he couldn't stop playing. He just had
Keep going.
going and exercising.
Right. Keep it going. Keep it moving. Don't let the moss grow on you. Keep it moving. Okay. Yes?
If smoking is cause or a major
Evil. Yeah.
number one, what are the statistics of other things? Are there certain foods or something?
What's number 2 and number 3 risk factor for development of rheumatoid arthritis? Yeah, it's a good question. Individual data on individual risk factors is very, very limited. You have difficulty because you can't say a particular population has the same exposure to certain things. Our impression, our impression is that the next most likely trigger are infections of some sort. Viral infections most likely, and then some bacterial infections. We know there's another group of illnesses called the reactive arthropathies, which is a form of seronegative spondyloarthropathy. Exposure to Salmonella, Shigella, Campylobacter, Yersinia, and chlamydia. Obviously, that's not GI, that's somewhere else, chlamydia. Those exposures can trigger this reactive arthropathy, one of the seronegative spondyloarthropathies. So there's literature all over about different exposures. You talked about things you eat. Very important. We sample our world. We literally sample our world on a molecular level by putting it in our mouth. Our gut samples, that's how we grew up. I was talking to the thumb. We learned by sampling in our mouth. If the gut is disturbed, if you are predisposed to reacting to certain substances, like high IgE levels or allergic to foods, your gut is sensitive to those exposures, and it can trigger an immune response. So again, we think that there are certain things that we expose internally. Smoke, of course, is one of them, but other foods, products, allergens, all possible. Okay, one more.
I noticed remission
Yes.
on one of your slides.
Yes.
So obviously it can go into a remission.
That's my goal. That's my goal.
Is there such a thing as it being cured?
Cured. Yeah. Okay, yeah, the question is, remission is great. How about a cure? Yeah. I can't prove that yet. I really can't prove that. I see folks in clinic that have had juvenile idiopathic arthritis of various forms. They come to the clinic, and there is no evidence of an inflammatory disease whatsoever any longer. That fortunately happens, 50 to 70% of the time. So the majority of the time, that's what happens to the youngsters. I can't say the same for those of us who develop rheumatoid arthritis later in life. Often, I get to the point where, Mrs. Jones has been in the clinic for 10 years, and I haven't seen a single swollen joint. She's off of every medication that she got. And I'll say the arthritis has burned out. Over many years, the inflammatory process has burned out, run its course. And then perhaps we're dealing with joint replacements for things that are toasted from long-standing inflammatory response, whatever. Cured is a strong word. Haven't been able to use that yet. Yeah. Okay. Yeah, one more.
How about climate effect on?
You say climate. How does climate affect arthritis? I'm going to change it a little bit. Instead of saying climate, I'm going to say sun exposure. There are series of autoimmune disease, and in particular lupus, in which the amount of radiation exposure, sun exposure, you can show differences in population statistics. People that live near the equator, higher risk of these sun-sensitive disorders like lupus, melanoma, other types of immune process, and then those that live in Canada or the North Pole, that they don't have that high prevalence of disease. In RA, I can't tell you that hot or cold makes a difference in the incidence, but I can tell you 100 patients, you say they feel better in the warm weather than in the cold weather. They feel better because it's more soothing to the inflammation. They feel like they can move better, not as stiff. So, well, I can't buy your ticket to Florida. I can transfer your records if that's where you want to go.
But there's temperature and there's also humidity.
True.
Is there any effect on that?
I don't know any data about humidity. Yeah. Okay, thanks, guys. Thanks for attention. Thank you.